I have the privilege today to interview Dr. Jack Fisher, formerly chief of the program at the University of California, San Diego, and here today to talk about his experiences. Jack, thank you.
Good to be here.
So my first question is always very easy, which is, would you please state your full name and date of birth?
Jack Fisher, June 16th, 1937.
Okay, and your parents' names?
Arthur and Catherine Fisher,
Okay.
of Buffalo, New York.
Ah. And were they in the medical field by any chance?
Nobody in the medical field. In fact, I'm still the only physician in our extended family.
What did your father do?
He was in hardware and paint sales. He became a regional salesman for a wholesale paint supplier.
Okay, and your mother's stay-at-home mother, you have siblings?
She was trained as an executive secretary, but she very proud of the fact that she worked every day through the Depression, but when she became a mother, she was a stay-at-home mom, later became a court clerk.
Okay. Any brothers or sisters? Or
Sister, living still in half the year in Buffalo, half the year in Florida. Okay. Buffalonians love Florida.
I understand. That makes sense. It's a temperature thing.
Yes.
And so you were born in Buffalo?
Yes.
Okay. And any children?
I have 3 children.
Okay. And grandchildren?
Oh, 4 of those, yes. One of them right here in New York.
Okay. And now the names of your children?
Janet, Stephen, and Susan.
Okay. Sometimes I have to think about my children's names. Sometimes I want to forget them. Depends on the day. And how did you meet Becky?
How
Your
did
wife.
I meet?
Your wife.
Oh, my wife was a nursing student at Millard Fillmore Hospital in Buffalo, New York. So it was a blind date, nurse, medical student.
Right.
We got married about 7 days after I graduated from medical school.
Ah, okay, okay. And you went to medical school at Hopkins, or
No, medical school in Buffalo.
Okay.
So I was in Buffalo for my pre-med and medical school, first 25 years of my life. Then when we left town, we headed for Minneapolis, and interns, those were the days of straight surgical internships.
Right.
And I did one at the University of Minnesota hospitals.
Okay. And what inspired you to go into plastic surgery?
At Minnesota, everybody wanted to be a heart surgeon, so I decided I was going to do something else. I rotated on a service where there were burns to take care of, and I got very interested in burns. I did my military obligation, luckily, at the National Cancer Institute, where there was a lot of head and neck cancer surgery going on without much reconstruction. Mm-hmm. And there were consultants who came in, and one of them was Milton Edgerton, who became my mentor. But Dr. Yurkevich came as a consultant, so that was a spark. These guys with reconstructive ideas caught my eye.
Yeah, you had 2 great plastic surgeons come up there. And this is part of the Berry Plan, or this was?
Well, I was part of the Berry Plan,
Yeah.
but I applied for and got the, they called them clinical and research associateships at NIH. So I did a year working as a resident taking care of patients and a year in the laboratory.
Okay. Now, you mentioned 2 mentors. If you'd like to say something about them, that would be great.
Well, Dr. Edgerton clicked with me, and actually Yash became a long-standing friend and mentor as well, but I met them both when they came in and spent a day with us. But I applied. I decided, I think, before I left Bethesda that I wanted to go into plastic surgery, so obviously applying to Dr. Edgerton was a natural thing to do, and he accepted me. But then he up and moved.
Yes.
Just as I was about to head for Baltimore, he moved to Charlottesville, so I went there with him.
Well, you had the privilege of being the first resident in a department of plastic surgery in the United States.
Well, I didn't realize, was that the first independent department?
Yes.
Okay.
Yeah.
Okay.
When I was doing my research, that
All
was
right.
the agreement that he had.
Oh, I
There's
knew
always
about that agreement. I
politics.
wasn't sure that his was the first department.
Yes,
Okay.
he started the first department of plastic surgery, which and I still see now divisions of general surgery, even with some of the icons that I interviewed, they still don't have their own departments, but that was one of the many contributions that he made to plastic surgery. They had an autonomous department.
Well, I have some opinions on that department and divisional issue. You may want to get to it later.
Oh, get to it now.
Well, there's a common belief that it is so important to be an independent department, but I always have argued that if you are an independent department, you still have to persuade somebody that what you want to do is important. And so now you're persuading the dean, and the dean has lots of departments that he has to deal with.
Yes.
The question is, what's the priority of plastic surgery? I can tell you that at my university, where I worked for 25 years, molecular biology was the priority, and plastic and reconstructive was well down the list. Now, Dr. Edgerton had his own reasons to be an independent department, but one of the reasons that plastic surgery flourished at Virginia was that he and Dr. Muller, who was the chairman, had an enormous kinship, and Dr. Muller was very supportive of the whole program. So had we been a division instead of a department at Virginia, I think plastic surgery would still have thrived, because we would have had the backing of Dr. Muller.
Look, during your career, you see momentous paradigm shifts in plastic surgery. And I'd just like you to talk a little bit about that. And you can mention, if you would, also the silicone implant crisis, of which you had some contribution to helping solve.
In order, yes, there are enormous changes in plastic surgery. Not all of them favorable, in my view. Maybe it'd be easier to talk about the silicone issue, since that was one that was ultimately resolved.
Absolutely.
And of course, I don't know whether I'm allowed to pitch my book, but I ultimately did write a history of that whole silicone affair. I was one of a handful of people. I was actually representing the foundation. It was at a time when Norm Cole was president of the American Society.
I interviewed Norm.
Oh, you've interviewed Norm, and he's probably told you about much of the battleground. The bottom line for that whole period of time was that nobody cared what the plastic surgeons thought. We were relegated to mercenaries who would pop an implant into anybody under any circumstance. We kept standing up and trying to wave the flag of scientific evidence, but when something hits the media, evidence goes out the window.
And junk science rules.
Oh, absolutely. And so the happy news is that ultimately the science prevailed, but it took 10 years. And it took an enormous expenditure of taxpayers' money with multiple commissions and studies, but the one that was definitive was the Institute of Medicine's. So the story I tell, actually in the book I wrote, is the beginnings of regulation in America, because what happened to silicone has happened to everything from caffeine and coffee to right up to today. There's junk science issues. So silicone is one of many, many examples. And I bring the story right up to the Institute of Medicine report, which absolved or eliminated all of the accusations of an alleged silicone disease.
Right, and I have a question, because I was in the fray of explant and, you know, the mass hysteria that occurred at that time. If there was, if you could call it that, but that's probably not a bad word. A lot of women had breast implants. But what is the name of your book?
Silicone on Trial.
Okay, and the period was unique in that the press was running that, and the personal injury attorneys were doing a great job of stoking the fire.
They'll jump on, trial attorneys will jump on any issue that they feel will put them in a advantageous position for negotiating settlements.
Right, and as, historically, the implants were off market for 15 years. Gel filled, saline stayed on. Gel filled was it 15 years to 99 to 2006, where till they came
91
back. 91
through 2006. See, even after the Institute of Medicine study, the FDA did not accept their findings. That's not unusual either, for one government agency to not necessarily respect the work and conclusions of another agency. In fact, if you go on the website of the FDA today and look under silicone implants and risks, they list connective tissue disease to this day as a possible risk of silicone implantation.
Did you look in your book? Did you looked at the studies in Sweden and Canada where actually the incidence of breast cancer was less? There was a Swedish study of 10,000 or 100,000 people where it was a significant decrease in breast cancer, like 30%. It was a wild number, and I talked to President Menner. I said, why doesn't anybody ever bring this up? What do you think of that?
Well, first of all, let's give Gary Brody credit for picking that up first.
Okay.
Gary is a hero of this story because it was in 1974 that people were talking a little bit about, I wonder what the impact is on breast cancer. And Gary was in Los Angeles. He was affiliated with University of Southern California, spectacular epidemiology department. Gary is still a person who understands collaboration, so he got that epidemiology team interested and began a study whose data was published before the so-called moratorium was called by the FDA, and it already picked up a little bit of a decrease in breast cancer. Since that time, it's been shown to be significant and substantial, and there are some reasons that have been proposed for why it's diminished.
What do you think?
Well, you know, I think it's a plausible theory that because an implant in the interface between breast tissue and the body reduces the temperature that the breast gland exists in, that in and of itself can diminish the chance of a malignancy developing. It's certainly true for testicular cancer, so why not breast cancer? I don't think that's proven, but it's a plausible theory at least.
You know, but it's a very interesting theory. Breast cancer is a study. I mean, Susan, the Komen Foundation, all these foundations, nobody's ever looked at this, but I guess it would be, breast implants would be an insurance-covered procedure prophylactically if, you know, such a thing exists, which is never going to happen.
No, nobody has an implant to prevent cancer. And we're learning so much about breast cancer now. That's a disease that is in major evolution, and genetics plays a major role. So, no, I think that.
Yeah. I wasn't asking you to say that. I just thought it was interesting that there was all this furor, and somebody said, well, maybe we should put them in because there's a decreased incidence in the two studies that I looked at, statistically significant and double blind, and had nothing to do with the size of the breast. That was one theory. Well, they're smaller, whatever, but we won't delve on that anymore.
The real folly of the whole silicone saga, though, was the fact that silicone was being used in so many other medical devices, implantable devices. I mean, in the 90s, well, we couldn't function today without silicone available to us, and we couldn't in the 90s. So many tubing and IVs, you name it.
Yeah.
And yet the FDA persisted in the false belief that only the silicone in a breast implant would cause diseases, but none other. So that was the huge error in thinking that one of our regulatory agencies decided to establish as a priority.
Well, David Kessler was a white knight of, you know, for the you know, the anti implant party or group, and he pushed that agenda, and he was head of the FDA. So, and I think he's at, where is he now? At Yale?
He's on the faculty of my university.
Oh.
But in the San Francisco campus, not the San Diego campus.
Did you ever get together with him?
No.
Okay. So, what do you think has been the most important innovation in our specialty during your career?
You know, we used to ask a question on the boards. There was not going to be a right or wrong answer, but we would ask, what's the most important technical advance in plastic surgery and all of plastic surgery history? And the answer that I was always looking for was the skin graft, grafting skin, being able to transfer a piece of tissue and have it magically revascularized. But hardly anybody ever gave that answer. It was always something in the reconstructive microsurgical realm.
Right. What do you feel has been your greatest professional accomplishment?
Oh, training residents. I'm a teacher, so teaching residents has been the most satisfying, and I think that's absolutely critical. That's what academic plastic surgery is all about. It's about innovation too, but if people want to know what has brought me the most satisfaction, it's training residents, and also, as I mentioned earlier, giving medical students an idea about what plastic and reconstructive surgeons do. We have, on a number of occasions at UC San Diego, accomplished the same thing that we did with you at Virginia, gotten a student excited and going on into the field. Always gives our dean's office a little bit of a worried reaction. They would much rather that they become molecular biologists or internists, but here they are, they want to become a plastic surgeon. So.
How many residents did you train? How many went on to be chiefs at other programs?
Ours was a small program. For most of the time I was in charge, we were approved for one resident at a time. It's expanded since. But we recently celebrated our 40th anniversary, and there were, and the newest resident was going to be the 41st resident. So that's small for a program. But you know, it didn't matter whether I was, again, a division or a department. Everything in the University of California system is according to a formula. There was only one state-funded faculty position for plastic surgery, and it was going to remain that way for quite a long time. So that kind of was the basis for defining how big we could get. There was also a push in California to have more primary care residency positions and fewer specialty positions. So that tended to curtail specialty training positions as well, and we were caught in that.
So you were the full-time paid.
I had the acronym is an FTE, a full-time equivalent.
And the rest of the plastic surgeons were a private practice that came in?
Well, no, they for us, the name full-time is, or the term full-time is applied differently in different places. If you are full-time faculty at our campus, that meant that every dollar earned passed through the dean's hands first.
Okay.
So we were full-time to that extent.
I got you.
We had a voluntary faculty, though, who were in private independent practice. We had a huge supportive voluntary faculty as well.
Okay, so what has been your greatest professional disappointment? And you don't have to have many, by the way. A lot of people just say, oh, I'm happy with everything, so unless there's something that stands out in your mind.
Disappointment. Well, I can't give you a specific disappointment, but I think anybody who chooses full-time academic work in any field has all kinds of plans and ideas that they'd like to put into action, but that's always limited by the availability of resources. So, you know, if I wanted to, I could lay out all kinds of dreams, but what I accomplished, I think, was not bad given the circumstances that we had.
Okay.
I'll say this, I was offered opportunities to leave San Diego and go do something else, and I decided that I was never going to have another opportunity where I got things started and I only had to deal with my own mistakes. I didn't have to inherit somebody else's mistakes.
Right.
So that was a one reason that kept me there.
Now, were you the first chief of that program?
Yes.
Ah, so you got to start.
I wasn't the first plastic surgeon. Tim Miller was there before me.
Okay.
Tim ultimately became the chief at UCLA, and Tim did the best he could, but he did not have a full-time salaried position. He was supported on the basis of clinical earnings. He did not have an independent division, so our chief of surgery did not give him what is necessary to build a program. And he recognized that deficiency and only stayed a year. And at that point, Harvey Zerum was taking the UCLA program on, and Tim joined him. And it was a smart decision for Tim. But I always appreciated the fact that at least Tim got there first and began to show people what plastic surgery could do.
Interesting, boy. That was a time back when when there was no program there.
Yeah.
Well, that's the evolution of our society. Who would you say you admire most as far as professional or personal?
My two models for academic surgery were Dick Egdahl, chairman of surgery at Boston University, and his principal sidekick, John Manick. John ultimately became the Mosley Professor of Surgery at the Brigham at Harvard. They were honest, bright. They were my models, even more so than I had lots of models within plastic surgery, but I have to give Dick Egdahl and John Manick primary credit for kind of giving me a standard that I could aspire to.
So what would be your greatest joy, professional otherwise?
Well, I derived an enormous amount of joy from my practice. I had to fight for that practice just like every other surgeon. Aesthetic surgery was suspect in our university environment, and yet the practice that I developed was predominantly people within the university community.
Mm-hmm.
Wives of professors would come to me, and one of the things we had to deal with in the consultation process was how are we going to break the news to their husbands that they were seeking cosmetic surgery, sort of something that was a little bit sub rosa to scholars. So the model of plastic surgery in our university had to be at the highest possible standard. I was in a community where there were very, very good plastic surgeons, still are.
Yeah.
San Diego's strong. So that brought joy. Even at the end of my term of work, I was still about 60% reconstructive and got up maybe to 40% aesthetic.
That's a pretty good
60-40, and of course, when you start out, you're 100% reconstructive and 0% aesthetic, and you have to build that practice slowly, just like anybody else does.
Right. And it was interesting in that time, the plastic surgery, cosmetic was hush-hush. Nobody talked about it, they just, now it's on every TV show, many in California, by the way, just talking about, which has advanced our exposure, but also increased others' specialties wanting to do what we do because they see opportunity there.
But when you are in a very, very pure academic environment, I'm very active now with the Emeritus Professor group at our university, and it's a diversity of people in every kind of field. Those people still are they're just not sure that they think that cosmetic surgery is okay.
Okay.
And in conversation, I can still make the point that plastic surgeons only do 4 things. They repair wounds, they graft tissue, they move flaps, and sometimes they insert foreign bodies.
Right.
Only sometimes. And I surprise people when I tell them that that's all we do. And that we do the same 4 things whether we're doing reconstructive surgery or cosmetic.
Right.
Same principle.
Right, right.
And then I have them completely confounded.
Yes. Well, because
sometimes students as well.
Yeah. Oh, yeah. I understand totally.
And then I do go on and say, of course, there are thousands of permutations of those 4 things that we do.
Right. Now, give me some of your words of wisdom for present and future plastic surgeons.
Sometimes when there is a very, very good student who has let our dean of students know that plastic surgery is their target, I'll get a call from the dean's office saying, would you have some time for this student? That is, if I haven't already spotted that person rotating through our service, because I still do attend our conferences. I'm having a greater difficulty. I don't want to deter someone's interest. But this is a difficult time for plastic surgery when the whole healthcare system is in chaos. Nobody at the organizational level of healthcare really wants to support reconstructive surgery well, like it deserves to be. And there's an even faster exodus in the direction of cosmetic surgery independent of the healthcare scheme. So my bias always is to try to attract students who have that curiosity to want to do some research, and who will recognize what Dr. Edgerton taught us, and that is deformity in and of itself is a dis-ease. That's a famous editorial he wrote. Deformity is a dis-ease. And it doesn't matter whether you want some perfections in your body or correction of a defect. You ought to approach both of those goals the same way. And I try to explain to students that reconstructive surgery always brought me as much or more joy than cosmetic surgery. But I don't know whether listening to an old guy like me makes that much of a difference. They're going to respond to what they see and what they do and what their experiences are. But our specialty won't survive if we don't capture some of those very bright students at the third year level and get them going. And we've accepted some of our wonderful students into our program and also sent them to other very good programs.
Okay.
So I'm often on the horn talking to some of the old guard that you're interviewing, who I still know, saying, hey, there's a student coming in the direction of your institution. We think very highly of him. And hopefully they'll get word to whoever is in the role of picking presidents.
And you're retired now, correct? So any words of wisdom about retirement or suggestions or what your retirement is like? I like asking. Some of my plastic surgeons I've interviewed are still actively practicing, but you mentioned, you know, you're associated with the university still.
I took sort of what I call a graded retirement. My first retirement was to give up that full-time position that I had and become a retiree in the terms of our university's retirement plan, and I gave up all administrative responsibilities because after a while administration gets pretty old. I continued my referral practice for another 5 years. I had some significant health issues at that point and decided to stop maintaining my own practice, and I continued to help out with the residents at the VA hospital. I don't do that anymore. And now I attend an occasional conference and, you know, make the kind of comments that old guys make about how we used to solve problems in a much more simple, straightforward way than sometimes they're coming up with.
Oh, I agree, yeah. Sometimes.
And then I picked an avocation. My avocation was history. And I had spent a lot of time on the freeways of San Diego because ours was a very decentralized system with multiple hospitals. And so I played audio tapes from history books as I went back and forth. 25 years of history audio tapes, you can get a pretty good foundation. But I went back and actually enrolled as a graduate student and earned a master's degree in history.
Oh, wonderful.
So I read, write, and research history now.
Any particular American history, all history?
I did U.S. history because I was language lazy. I did not want to have to bring a language up to speed, because if you do that, you have to do research in that language, archival research. So I was U.S. political, economic history. Since I had experience with statistics, I could handle the numbers better than I could handle sorting out one philosopher from the other. I never studied philosophy formally, so economic history was perfect for me. But my reading is eclectic, and all of my writing projects have been completely different. It's not like I'm in any single area of history.
What predictions do you have for plastic surgery in the next 25 years?
Oh boy. Well, let's see, what could I predict with certainty? Number one, 25 years from now, in public institutions, there will still be a lot of people rolling in the door with god-awful wounds, and nobody will want to take care of them or know how to take care of them except for plastic and reconstructive surgeons. And people won't be fighting for the bed sores.
Right.
So I would imagine that our specialty will continue to be based on problem wound care.
Okay.
That's how we built the practice in San Diego, is we smiled and said, we will take any wound you have off your hands and see what we can do with it. So beyond that, it's awfully hard to make predictions 25 years ahead.
Very few people want to make predictions. I just like to see, because somebody is going to see this at some point.
Right.
And
well, here's another one. Okay. People
You're not being graded on this.
Okay, great, thank you. People will still want to look better 25 years from now. They'll still be born with variations in physical structure that can be altered. And I suspect that if our specialty is intact, that we'll still be inventing and finding the best way to do something, but then it'll be copied by other specialties.
Yeah.
So other people taking over what we do, that's not new, and it won't end.
Jack, thank you so
Okay.
much. It was a pleasure.